Well, good afternoon and welcome to the program. This is Reset on OurTV.network, Health, Wellness, and Lifestyle with Linda Dorman as your co-host. That's me. And I'm so pleased to see my host, but I'm pleased to see my co-host, Dr. Donna Christensen with me here today, this afternoon. We have a very important topic as it relates to cardiology, and we are joined by our esteemed guest, Dr. Paul Underwood. Welcome to the program. Well, Paul must be in the back office. So what we're going to do is we're going to
Here
introduce.
he comes. Here he comes.
Great. Welcome, Paul. Welcome. We just
You're
welcome
welcome.
to the program. I want to give a little bit of your background because it's so remarkable. And I'm going to start with where you are today. Dr. Underwood is an interventionalist cardiologist, and we'll talk a little bit about what does that actually mean, with over 30 years of experience in private practice. He completed his medical school and residency at the Mayo Clinic and completed cardiology training at the world-renowned Cleveland Clinic. He learned interventional cardiology at Iowa Heart Center and practiced interventional cardiology in Phoenix, Arizona, where he is right now. And I'm sure it's nice and warm over there, I hope.
Absolutely.
He has been an influential member of the Cardiology Society through the Society of Cardiac pronounce that one more time for me.
So angiography
And intervention, and the American College of Cardiology. But most notably, he's a life member of the former president of the American Black Cardiologists. I want to also point out, while under your leadership, and I believe that you were in 2004 and through 2006. So you've had a long history with the organization and did some formidable work as it relates to cardiologists and heart disease and African Americans. And one of them was to manage and unveil the results of an African American heart failure trial, the first study conducted in heart failure population, in which all of the participants identified themselves as Black. But what's really critical, and let's talk about that as well, is the results of the study led to the production of the drug D-Bile, the first ever heart medicine specifically geared towards African Americans, the racial demographic with the highest percentage of heart disease. But there was a beginning. Besides your studies, you in 1987 landed in the wonderful island of St. Croix, working for the St. Croix Hospital in the United States Virgin Islands as Director of Emergency Department and Intensive Care Unit. And I bet you, when you see Dr. Christensen, who's sitting in St. Croix right now, yes, brings back old memories, because you two have a special connection.
Absolutely.
It's really wonderful to see you again. And even after I stopped practicing and was in Congress, I would see Paul from time to time, either at an NMA meeting or at our brain trust. And we interacted quite a bit with the Association of Black Cardiologists.
Absolutely. But Donna, you have always been a leader and at the forefront from even back, say, when I started to the current time of absolutely right now, that you have been pushing health issues and across the country, not just for the Virgin Islands, but for all of us here. You've been a sounding board and an advocate for better health for particularly minority Black communities. So I really appreciate your leadership and what you've done for us.
Thank you, but I couldn't have done a lot of that without the backing of the Association of Black Cardiologists and doctors like you.
And I'm going to ditto and echo the accolades, because it's been such a pleasure to have Dr. Christensen really serve on this program, give her expertise, her voice, and really such a pleasant person to really dialogue with around these really critical and remarkable issues, both at the treatment level as a practitioner and her family practice, and I'm sure in yours as well, Paul, but being one of the strong voices in the halls of Congress, which is formidable, not just for the Virgin Islands, but for, as we call, the mainland, the continental U.S., and really have a voice that resonates and replicates all across the world. So thank you, Dr. Christensen, and Happy New Year to both of you.
Yes, Happy New Year, everyone. Happy New Year.
Yeah, so
So,
we've had a lot of conversations in the past with amazing cardiologists, and you joined that lineup of esteemed physicians that are really focusing on heart health. But you are an interventional cardiologist. Let's just help our listening and viewing audience understand what exactly does that mean. Is there something different we need to understand as we start our dialogue today?
Well, certainly. Thank you, Linda. And I'd like to just maybe just open up for the audience kind of what the heart is. So it's a muscle, and it has a blood flow that goes to it. It pumps. It has a certain rhythm to it, so it's got an electrical circuit that's in it as well. And then it also is fed by blood, so the coronary arteries that actually feed the heart are important as well. And I'm sure that we're all kind of aware of what a heart attack is when one of those arteries becomes blocked. Well, an interventional cardiologist basically unblocks those vessels. So we perform angiograms, which is just using dye, usually going through the leg or now through the arm, to take pictures of the blood vessels feeding the heart, and then if necessary, we may be able to put in a balloon or a stent to make sure the blood vessel stays open. And there are many other aspects of interventional cardiology, but that's really basically what it is. And so a lot of the patients that I have seen have been patients who have blockages of their arteries, which gives them angina, so chest pain with exertion, or they're having heart attacks where the blood vessel is closed off all the way.
Would that be in the same family as having a stroke as well, or is that something slightly different?
Well, it's slightly different only in the sense that the process that I just described is happening to the heart. With the stroke, it's happening to your brain. So it's a closure of the blood vessels going to your brain leads to a stroke. A closure of a blood vessel going to your heart leads to a heart attack. That's what we would call
Okay.
a heart attack.
All right, that's a good distinction for those who need to understand that, because
and don't
sometimes.
they sometimes happen together? You have a heart attack, and because of the drop in your blood pressure and so forth, you can have a stroke as well.
Absolutely, absolutely. And so that term heart attack can mean a lot. And so I think oftentimes when we speak in our communities, we talk about people who have had a massive heart attack, which typically means a heart attack that you didn't survive. And
Mm.
so and in those situations where the heart is so badly damaged that it can't provide blood to the rest of the organs, then absolutely having a stroke and other organ damage is possible too, because the heart's function isn't able to keep up.
Well, it's a interesting specialty. So when I think about a cardiologist, and I've been to a cardiologist because I thought, oh, my heart is beating so fast, I'm not sure if this is normal.
Yeah.
And then I find out that I'm just stressed, so I got to take all the measures to relax me on a daily basis. But those who have different symptoms, can you share with us a little bit about at what point would someone come to know to see you? Or they first seen a cardiologist without the specialty, but you're in the surgical suite? Or would I say I need to call up my interventional cardiologist?
Well, typically there's an introduction that's made. And so we are subspecialists. So you typically would be referred likely from another cardiologist. If you come in with a heart attack through the emergency room, then the emergency room doctor will call us, and then I will be the first cardiologist that you meet. But say typically for someone who has noticed that they have chest discomfort walking up and down the steps, they likely would speak to a primary care physician, and that person would do an EKG, and they would say, oh, I think I need to send you to a cardiologist. You will go to a cardiologist, and they likely would do a stress test, which appears abnormal, and they'll say, I think you need to take some pictures of the blood vessels feeding your heart to see if there are any blockages there and to see what can be done about it, right? So then that's when you would meet me. And then we would go it's like a surgical suite. We call it the cath lab, the catheterization lab. And it's in this room using an X-ray that we would then inject dye into the arteries feeding your heart. And then we can see how they're situated, if there are any blockages or not. Hopefully there are no blockages. But if there are blockages, is it something that we would be able to treat with just medicine, or shall we treat it with a stent, or should we actually consider having open heart surgery for bypasses?
Wow. So let's kind of first get a little bit of why did you decide to go into medicine, And why did you decide to actually focus in on things pertaining to the heart? It's always a good story to understand the person behind the scalpel, because that's what I understand you're
Right.
doing.
It's certainly, I think, early on, I believe that I've had an interest in science. So in high school, middle school. So I've liked science, and then the ability to help people. I I was in a little, like a taxidermy class when I was a senior in high school, and I had a dog's leg that I had to dissect, and that kind of at least got my juices roiling to actually go into medicine. And so I did that as pre-med. Now, certainly going through medical school, there was no one else in my family that was a doctor, so I really didn't know the different types of doctors that were around or what they did. So I was looking more generally through medical school. But when I came to St. Croix and in the emergency room, I got to see a lot of different problems. And what interested me the most at that time, and still does, are heart problems. And that's when the decision was made to go into cardiology. I think I was looking more toward other procedures because I like to use my hands, so more gastroenterology, but heart disease, people having heart attacks, doing CPR, rushing them into the cath lab, opening up the vessels, things that really interested me, and that's what I have focused on basically for the rest of my life.
Can you
So
talk
that's what
a bit about the about heart disease, cardiovascular disease in African Americans? Is it more prevalent with us than, say, the white population? And
So overall, so cardiovascular diseases, as you know, it carries. There are a lot of different types of cardiovascular diseases, right? And high blood pressure is like the first one. It's kind of like a precursor for all those that follow. And definitely, high blood pressure in African Americans is much more prevalent, right? Then if you look at deaths, just people dying, that there's an excess of deaths in African Americans from cardiovascular disease. So that would be heart attacks, strokes, heart failure. There's We die more frequently than whites do die of this, but it's a major problem overall for America and other countries too, heart disease. But it seems to be, as many problems are, more of a problem for us in our community. And I think that there's a lack of awareness, and that's what the Association of Black Cardiologists has been fighting for almost the last 50 years, is to make sure that people are aware that, cardiovascular disease in African Americans is important too. And we need to do what we can to prevent this from happening and to shorten our lives here with our families and to keep our grandchildren from being able to see us.
It's so disheartening to hear that. I did hear that, like so many other things, we suffer and we are number one on the list. And I'm trying to understand, which is part of the reason and purpose for this program and this platform, is to provide our listeners and our viewers with information they can use. We write, I have a notebook that I write. If you see me looking down, it's because I'm writing notes. Because I'm interested for my family and myself in my community. I'm trying to understand, what can we do more that's going to help change that trajectory, decrease that disparity, rank us down lower in the list. Are we just not hearing the call to action in this whole entire issue of heart disease and other issues? Are we just predisposed based on our genetic makeup, how we live? What would you say, looking at your clients' common threads that we all might understand better?
Well, so I think part of it is a message and keeping up with the changing times. So in the past, say 10, 15, 20, 30 years ago, a person would go to the doctor would do something, and then you would leave. Well, in today's day and age, you really have to be much more informed as a patient to make sure that you're going to get the most out of your visit to the doctor or out of your health in general. So we can't pretend like things are as they were in the past, where it was really very passive. We have to take a more active approach. And when I say the message, that messaging even for what the risk factors for heart disease are, the American Heart Association has been doing this for quite some time. But if you ask, a group of blacks and a group of whites, only recently has the knowledge of those risk factors been equally distributed. So there's a
Mhm.
lag for this information getting to, permeating African American communities, right? And so now that we're changing more to, like you said, telemedicine, I saw on the introduction, with telemedicine, well, we've been a little bit behind in the digital uptake, and so that's going to put telemedicine out a little bit. We have to make sure that we're on the forefront to get to a higher level of the available technologies so that we can help ourselves, right? And that's so we have to be more informed, and that's what I would suggest for people of no matter where you are in the United States at this moment. Everyone should be insured, thanks to the Affordable Care Act.
Yes.
There's some with whatever your basic level of coverage is, you should make sure that you use it for wellness as much as you possibly can. I mean, certainly some people's plans are better than other people's plans, but there's a basic that's there, but no one's going to like force it on you and give it to you. You have to actually go out and get it and use it yourself, right? And then the other part is risk factor, understanding what the risk factors are, and then knowing what you should do to be able to control those risk factors. So there are genetic things like your family history, maybe diabetes. So some of those things are kind of programmed into you already, high blood pressure. But once you recognize you have high blood pressure, then it's kind of up to you to do what you can to control it, whether it's diet, exercise, taking medicines, taking your blood pressure at home to make sure that it's controlled, that you don't need more or less of this, that, or the other. So a lot of that is now relying on you, not necessarily your doctor, and
Absolutely.
understanding that the impact of your blood pressure being high or low doesn't really matter as much to your doctor as it does to you.
Yes.
And you should pay attention to this yourself so that you can enjoy the best results.
I
And
like
live longer prevent heart disease and kidney disease and all of
Oh, absolutely.
those
Absolutely.
complications. But the social determinants of health are also a factor, where it's difficult. Where in a particular neighborhood, it may be difficult to exercise. You may not have the fresh vegetables and fruit.
Mhm.
Education being maybe substandard in a lot of communities of color and in rural areas. Uh, it's hard to be health literate if you're not well literate generally. And
Right.
in addition to um, the personal responsibility that we must be taken to make sure that your blood pressure is under control, your diabetes is under control. Um, there's things that need to happen around you to make it possible for you to really do the things that are important to maintaining your health and quality of life.
That is absolutely true. And so the advocacy that takes place of things, as you said, in your community, in your environment, is extremely important. And I think, I mean, we've recognized that for some time, but I think that now it's much more apparent, and particularly during this time of racial reckoning and
Yeah.
understanding systemic racism and how these other factors can impact on one's life. That certainly impacts on their health as well. And so we've seen some healthcare systems that are now venturing out into social determinants of health, and some providers are looking more towards social determinants of health because they know that those interventions can improve outcomes as well. And again, with those, it's important for the individual to know what resources are available there. Just as you said, if it's a food desert, there may be farmers markets that come every other Friday. You would need to know that to then go get the vegetables in. So there sometimes are approaches. There maybe like band-aids or to help some of these issues, but it still is up to the individual to reach out to them, to understand that they exist, and then to go interact with them in such a way that is going to be beneficial for them. And then obviously to build on those to make it such that it's no longer a band-aid approach. The system has been reconfigured so that you actually do have healthy spaces to exercise. You do have access to quality nutrition.
And I think it's so important. This as we talk about interventional cardiology and the heart and heart health, I think you've brought a very good point forward, both of you, Dr. Underwood and Dr. Christensen, in terms of when we think about the social determinants. And because we seek to educate our listeners and our viewers, we want to make sure that individuals really understand the terminology social determinants of health, because it has its own acronym, SDOH. In the health community, we know that very well, but they are the economic and social conditions that influence individual and group differences in health. And of course, we're talking about communities of color where there is just, food deserts, there is technology deserts, there is educational deserts, there are job gaps and things that indicate those social determinants of one's health. And so what you're just sharing is that now that we understand this systemic racism, we certainly know there is an inequity and inequality in health and even in the treatment of health. It's very staggering that we would still be where we are today, but it is the responsibility, and you mentioned that very well, Dr. Underwood, that we really are our first interventionalists. So if you know that you have high blood pressure, then it is time to do the things that are going to manage getting you off of the medicine if you're on it, being aware that you might take it, and then continue to do the things that you need to do. And so, when we go forward, you mentioned something also that I thought was really important. And I know we're going to probably come up to the break, but let's get started. And one of them is you mentioned technology. Because I imagine that what you do requires technology. And it seems that there is a trending in cardiology for more advanced technologies to do the work that you're doing in the most sensitive parts of our bodies, and that is our heart, as far as I'm concerned, along with our brain, but our heart is a pretty big one. So can you share a little bit of how you actually go about your treatment if there is a blockage, as an example? Because I
Sure.
think that's the challenge, Dr. Underwood. I think part of the concern is the challenge with fear of what does this really mean? If I don't go to the doctor, if I don't get listened to the diagnosis, if I don't take the steps, then somehow I'm going to prolong what I'm doing. There's just this procrastination. Okay.
True. I think that overall, sometimes we carry this idea that we should just keep on going as long as we can. And then when something happens that stops us from like going to work, that's when we would seek help, as opposed to being a little bit proactive. There's also this desire for something just to go away. Like, this ailment came on me. I have chest pains when I walk. Let me just walk more slowly. It'll go away eventually. But for heart disease, it likely the blood vessels going to block off and you're going to have a heart attack. So it pays to pay attention to this more sooner than later. With technology, having access to like in the neighborhoods that we're talking about, social determinants of health, having hospitals that have cath labs that are available 24/7 is very important. There are new procedures, like we were able to replace aortic valves, not necessarily with open heart surgery, but through the leg, which is a brand new technology. But having access to those in your neighborhood may be difficult for some neighborhoods, and that is another access issue in social determinants of health. And those barriers sometimes prevent us from getting timely care if you're having a heart attack, or having access to these life-saving procedures if you need them, because they're not really accessible to you. I mean, they may be available, but they're not really accessible to you. And so navigating the healthcare system is very important. The ability to navigate is very important.
Well, we're going to come back in just a few minutes. We're going to take a quick station break, and we look forward to more conversations with Dr. Paul Underwood and Dr. Donna Christensen here on the Reset Program, Health, Wellness, and Lifestyle with Linda Dorman. We look forward to picking back up in just a few minutes.
Time. It has a different meaning in the U.S. Virgin Islands. It goes backwards, forwards, it stops. St. Croix is rooted in history. So much of it still remains untouched.
I remember running on these streets as a kid. This trap was right down there. It opened the same year I was born. This is where the original Crucian hook was born. It's the symbol of these islands. And I wanted to have my hands in that very same history. I want to be able to pass it down to my family while still putting a new spin on it.
The U.S. Virgin Islands, we have an amazing culture that developed over time from all over the world.
St. John feels so untouched. Being underwater is like another world. There's no worries, there's no stress. I can just escape. This is my happy place. My passion for scuba diving came at just being fascinated with the water and wanting to be a mermaid. And this is the closest thing I can get to achieving mermaid status. Canadians just love being outdoorsy. We live for adventure, so we love anything hiking, being on the water, diving, snorkeling, and St. John has it all.
It's like some spirit is protecting the island and keeping them raw. The Makujumbi watches over the island. From up there, they keep the evil spirits away.
Get down.
The nightlife in St. Thomas is absolutely amazing. There's always something going on. Everyone comes together to dance and catch a vibe. We're always celebrating. We celebrate freedom, culture, the food, the smell, the music. It's always a celebration. The people here are probably the most priceless thing because they keep the culture going. There's so many different influences on these islands. Food from all kind of countries coming together in new dishes. All of us came from somewhere, but all that we call this home. The VI is the new melting pot. This is where the past and the future comes together.
Welcome back to the program, everyone. And we're here with Dr. Donna Christensen, co-host of the Reset program, Health, Wellness, and Lifestyle with Linda Dorman. I'm your host, and our special guest, Dr. Paul Underwood, broadcasting from OurTV.network. And we're talking about why it's important to understand interventional cardiology. What does it matter to us, and how do we become our best health advocates and our best health consumer? So before we went to the break, we were having a conversation around technologies. And you mentioned something that I thought was very interesting. I want to kind of circle back to that, and that is you go through the leg, one of the procedures that you can go through the leg up to the heart and create what you need to
To
create
replace the valve.
to replace
Yeah.
a valve.
Or repair a valve.
That's
Right.
It's amazing, because it used to be
Absolutely.
open heart surgery.
Right. And so that is a problem, because it used to be typically this disease affects people who are older, so they're in their 80s and 90s. And then if you ask someone that's 80 or 90 years old, would you like to have the valve replaced, which means like open heart surgery, they typically would tell you no. I mean, in no uncertain terms. So that now the conversation has changed a bit, because it's not really quite like an outpatient procedure, but it is, you're going through the leg. It's minimally invasive. You can replace the valve. So now those conversations actually need to come up, because the person may say, yes, it's going to relieve my symptoms. And with this particular illness, if you have severe aortic stenosis, there is a good chance that you won't be around a year later. So there's a very finite lifespan that's associated with that diagnosis. But with the replacing the valve, just opening up the valve so the heart can pump the blood out, you've really expanded your life expectancy tremendously, right? So the doctors need to know now that instead of just saying, that this is your diagnosis and this is the way it's going to be, don't, make amends, that there may be other technologies available for them now. If your doctor isn't aware of that, or isn't really hooked into the network to refer you there, or it's too far away, or for whatever reason, then you still don't have, that patient still will not have access to that technology. And that's where we will, that's where we lag. That's exactly where we lag, and that has been shown to be true.
So if I'm hearing you correctly, and Dr. Christensen, just hop in, is that if that doctor doesn't make the referral, then that's where one of the lags occurs. Is that correct? Am I hearing
And
that?
that's why, as Dr. Underwood said, it's so important for you to be more proactive about your health, and know what is available to you, because there's still discrimination in healthcare, and there's sometimes when the thing that you need may not be there. You may, especially in a place like the Virgin Islands, you may have to go off island. So it's really important for us to make sure that our population is well informed as to what can be done in many different circumstances.
And I wonder, Dr. Underwood, is that much of your work now with, you're with Boston Scientific Corporation as its medical director, and you're also the medical director over a program called Close the Gap. First of all, that sounds intriguing, Close the Gap, based on our conversation today. And that's the Health Equity Education Initiative of Boston Scientific. So cheers to Boston Scientific for helping to drive that home, that health disparity down through education. Can you share with us about that initiative and what Boston Scientific is endeavoring under your leadership?
Certainly, it's certainly my pleasure. So Close the Gap has been around for almost 15 years now. And it started off looking at people who have heart failure. So if you have heart failure, then you're more apt to have something called sudden cardiac death, right? So your heart gets an abnormal heart rhythm, and you have what they call ventricular fibrillation, and then you'll die. So that's when you see people with CPR and they get the paddles. Okay, it's that particular condition is the condition that I'm speaking of. And what happened probably, say, 20 years ago, I guess probably longer than that, but anyway, that we've developed something called defibrillators. So we found that those people who are at risk, who have weak heart muscles and who are at risk of having sudden death, that by implanting your own personal defibrillator, they don't have to die, basically. And so understanding that Blacks and women have more heart failure than whites and men, right? And then seeing who was actually getting these defibrillators, there was a gap. And so Close the Gap was initiated to make people aware that there are these technologies that are available that can prevent you from dying early if you need them. Now, not everybody needs a defibrillator, but if you need a defibrillator, then your chances of living are much better if you have it implanted than if you don't. And from that's the start. And we've since then gone to look at other areas of disparities to help clinicians, providers, doctors understand the disparities and kind of their role in them and what can be done. Also to help patients understand what they need to do to protect themselves from, being prey to the system and not getting the health care that they need. And so that's Close the Gap's mission, and it's evolved in different forms. We've looked at coronary disease. Now we're looking at peripheral vascular disease, atrial fibrillation. There are many aspects of cardiology that warrant reducing disparities. And Close the Gap tries to work with practitioners and patients, patient groups to help to narrow that gap so that people can have access to the care that they need.
Well, we applaud, we support, and we will continue to advocate and lift up Boston Scientific and your work as medical director of Close the Gap program.
Because well, thank you. It's teamwork, believe me, teamwork.
Yes, and we want to, and those of us who are health consumers, and that means everyone that's listening and hearing and seeing us, you are a health consumer, so you're part of that teamwork as well. Because I've often wondered when you said the defibrillators are you talking about the pacemakers? Is that the kind of generic term? Is that what we're to understand? Because I remember my mom had a pacemaker inserted and she was really opposed to it. And I just could not understand if that was going to extend her life and give her quality of life, allow her to go play golf and do all the things that she wanted to do, travel around the world. I couldn't understand why she would not want to have that device inserted. And she felt that it was very unnatural and very unnecessary, that she could do it in some other holistic fashion. Is that what we're talking about when you mentioned that particular terminology?
It's similar to that. So it's based off the pacemaker technology, but a pacemaker technically is there just to keep pace, right? So if your heartbeat is slow, the pacemaker reminds your heart to beat, and so it keeps it from going too slow. The defibrillator is on the other side of that. So if your heart is beating so fast that it can't fill with blood, then the defibrillator sends a shock. It's like the paddles that you'll see on ER, or Grey's Anatomy, those paddles. It's that is what the defibrillator is. They're in the same kind of canister, the form factor looks very similar, and they're implanted in the heart very similarly, but they do have different functions. And you have pacemakers that can defibrillate also. So they're combination devices as well.
Oh, wow. You can have a combo device. And so I think we should just encourage our listeners and viewers, if you are heading in that direction or you're with a loved one as a caregiver that is about to undergo these types of procedures, to give some hope that you can live a vibrant and continual life and quality of life, high quality life, because the technology is so innovative. Every day there's a new innovation. I'm quite certain somewhere in the world that's bringing this, and those who are doing the research and understanding of this new technology and bring it to market for our good is very important. And Dr. Underwood, tell us a little bit now about your work at Boston Scientific, because this is a name that we know so well, but we don't know exactly all the details of what goes on behind the corporate doors that helps us to be where we need to be in terms of our heart. Just give us a little insight to that.
Well, certainly. So it's a medical device company, and so for my business, it's cardiology. So we make the equipment that's used for interventional cardiology. So it requires guide catheters to take the pictures with, wires, balloons of different sizes to meet different vessels. Different types of imaging equipment, like little ultrasound machines. We make the valves that I just spoke of that go through the leg. So those types of things we produce, and they're used in hospitals to treat patients who need them.
Do you think? Do you think, Dr. Underwood and Dr. Christensen, do you think we're going to get to the point where our homes are going to be outfitted with those types of technologies that we are able to go in, put our hands to it, or touch our telephones and be in a position to transmit information that's critical to let us know that we have a warning? There's something not going quite right in our bodies that we don't intellectually have our head around.
I think some of that is possible now, but I'll let Dr. Underwood respond because I'm not in
No,
practice.
I agree. So there are some technologies that are there, just as you said, that can use your cell phone to diagnose things. A simple one is abnormal heartbeats like atrial fibrillation, where there's an irregularity of the heartbeat. So most phones now, there are apps that you can download that will be able to detect atrial fibrillation just by putting your thumbs on the phone. And so some of that technology is here. There are people that are currently working on that because that is digital technology, definitely. And certainly you're very well aware of in-home testing that's available now as opposed to the past. So not necessarily phone-based, but just being able to go to the drugstore and pick up a COVID test, right? For one, I guess now, as of today,
Maybe.
you can just order one. You can just order one online, right? So
Right.
you can get your COVID test to come in. Pregnancy tests, you can test for different types of allergies. There's, blood sugars, continuous glucose monitoring, where you just wave your phone over it. You get to see your blood sugars over a range throughout the day.
And
So
send it to your provider. Yeah.
absolutely right. So there's a lot of technology that's available now, and the technology does keep moving forward and moving forward. And I do think that our health overall is going to be related to how well that technology enters our community, right? If there are delays, then it means that we're going to lag in our health, right?
And
It's just
disparities
easy
get
to,
worse if they don't get to everyone that needs it. I remember when we had Holter monitors.
yeah, right.
If you wanted to track someone's heartbeat, if you thought they were having an irregularity, you walked around with something like a little, like maybe compared to might be a computer case or something like that,
Yeah.
about that size. You had to walk around with it and press a button if you felt it was.
Right.
So I mean,
Yeah.
things have really changed, have advanced over the 20 odd years that I've been out of practice.
But
Yeah.
isn't that, when you say walk around, are you walking around in the hospital though?
No, you take it home. You would take that home,
Oh.
but now you can have a watch that will check to see if you have an arrhythmia
Yeah.
and send that information
Because
out.
I wondered if we should, as part of any effective or extended CPR course, be certified also in your home for the automatic external defibrillator. I know that churches are now putting them in. Places of businesses have been doing so, not just your fire department or your EMS, but places where there may or may not be a nurse or a healthcare
Absolutely.
practitioner, where JQ Public and myself are getting trained to operate them in case they need that external paddle.
Absolutely. So that comes as part of, certainly from American Heart Association, part of CPR training. At the very end of it, once you go through the chest compressions and the rescue breathing, they should have a session there on automated external defibrillators. And just as you said, so that you are at least aware of them and how they work in case you happen to be in an emergency situation, to, for one, ask for it, and then to kind of know how to apply it, since they're all fairly standard. So that is taking place. Again, in our communities, bystander CPR and access to an AED is less, right? And so that's a problem, that if you happen to have a heart attack, a major heart attack in Black communities, you're less likely to have bystanders get you to be able to survive than if you did in the white communities.
I think that you've made a remarkable point in the simplicity of actually the American Heart Association and hospitals, the American Red Cross all deliver CPR courses that are either free or affordable. And I think it should be noted that we should encourage every single person that can hear us and that can see us that take the time. It's not a lengthy course at all. I mean, what is it? Just a few days?
Not even a few days.
Not even
It's
a few days.
one day. It's a few hours. Yeah.
A few hours, because I remember as a Girl Scout that we, old school, we did a couple of days, but now we're saying 1 day's time will give you the education that you need that might save a life. And I would think that to better understand how to save that life as well as yourself. And I know that it's important, particularly if you're a new mother, you want to understand how, if anything happens with your newborn, it's important to get that CPR training as well. And so, and then I wondered, because some of us have pets that are, friends of us, that I know that there is a pet version of that CPR. So we say that not in jest, we say that importance because during this pandemic, many of our listeners and viewers were so isolated, obviously, but their pets became even more important to them as comfort. So, one of the things that I'm always curious about is what's happening in the industry, the trending. Are you seeing a lot of students who are entering medical school come into the field of this particular specialty of cardiology? Because this has to take a remarkable amount of skill to do what you're doing. It's hard to wrap my head around it, quite frankly, and I, applaud you.
And heart disease is the leading cause of death.
Yeah,
just about everywhere.
So still, there is interest in people pursuing cardiology careers, and then within the cardiology career, and I think you touched on this a little bit earlier, that there's preventive cardiology. There's also like imaging cardiology, which uses MRIs, CT scans, ultrasounds. So that's still kind of non-invasive. Invasive cardiology, which is the field that I'm in, so it's interventional cardiology. We have electrophysiologists. So when you said that you had the fluttering heart, there's a group of cardiologists that specifically look at racing heartbeats, and they're the ones that put in pacemakers, defibrillators. They can do ablations. So it's that field. So cardiology has multiple facets that are very interesting, and there's a lot of research going on in the field now, so that does attract young people to come into the specialty, definitely. But having the knowledge there, we need to permeate some of that knowledge to primary care physicians,
yes,
and then down to patients as well, so that everyone is informed. The best thing that from an interventional cardiology standpoint, and the person, is that you should do everything that you can do to keep from having to see me. If you happen to live long enough to develop aortic stenosis, that may be a different story. But for blockages, of your coronaries that come from uncontrolled diabetes, uncontrolled high blood pressure, having your cholesterol, too high, if it's those types of things that you could prevent or you could control to prevent you from seeing me like with a heart attack, that would be what you would need to know. Not necessarily the types of stents and wires that I would want to use. It's and after I treated patients and stented them, my goal was to make sure they didn't have to come back for more of it. That was their turn, and now we're going to try to turn things around so that doesn't happen again. Right? That's the mindset. So we want to make sure that if we can prevent it from happening, yes, and definitely if we can prevent it from happening again, yes.
I think Dr. Christensen, we should go in our next program. We should really have a broad panel on all things prevention, because this is the key, prevention. And we as Americans have a diet and a lifestyle that doesn't necessarily always conform to prevention until something does happen. So what you're saying, Dr. Paul Underwood, is when we see you, we're in a little bit of trouble. But we will get through it because you are skilled and highly trained and highly educated, and you have the knowledge. And part of that knowledge has to be how to work with communities of color. And here again, I want to ask about two things. One, clinical trials and what we talked about, the drug that came out, and how did that clinical trial come about? I mean, it's so important that we participate in these trials. How would we even know about them?
Certainly. So this trial came about after a Veterans Association trial on heart failure, looking for different medicines, and kind of as a byproduct of that initial study back in the 70s, it was seen that there was more effect for this drug in Blacks, and so then the next step would be to try this drug specifically in Blacks who had heart failure, and as expected, there was a marked benefit by using this drug. And so presenting that information to FDA led to the approval of this drug called Bidil, which is just a fixed dose combination drug for use in African-American patients who had heart failure. So that was the first drug that's ever been approved by FDA based on race. And the uptake in the physician groups has been sluggish at best. It's on the guidelines. So like the Heart Failure Society of America says that, African Americans, you should use this therapy. A lot of clinicians, typically they don't like to acknowledge that you're an African American in that sense, so that they treat you for heart failure, but they don't really see the role of using this drug because it's race related in that sense. And there's a lot of pushback for using it. And so the acceptance of that particular medicine has been low. So that's as it is on that particular therapy. Now, overall for clinical trials, African Americans, to be a participant in a clinical trial, you have to be associated with a center that knows that is doing that trial. So you can find something on clinicaltrials.gov, and then you would go to that particular hospital and then ask to see that investigator and see if you can get in that study. Or if your doctor is an investigator, then they would ask you to be in that study. And so
I did a clinical trial before I left my office. It was a heart study. It was around blood pressure. Using you probably remember, it was a really broad one that was run by a Black cardiologist, and his name is escaping me right now.
Probably Keith Ferdinand.
No, before Ferdinand. Older than Ferdinand.
Okay, all right. So
yeah, Jackson Hart.
Yeah, right.
Jackson
so Jackson,
study.
right.
Yeah. Yeah, I participated in that, and my
all
patients
Did you?
That was it.
Dr. Christensen, did you participate as a patient or as a physician? As a physician.
Yes, and I had my patients enrolled. I had maybe about 10 patients enrolled in it. That was my first
and I think that's such an important point, is that when we talk about individuals participating in clinical trials, we also need to encourage those physicians and clinicians that you too, they need your support. Is that not true? To also participate in
absolutely. If Dr. Christensen wasn't an investigator, then those patients would not have been all HAT participants, right? The people who were practicing next door to you who weren't all HAT investigators, those patients were not in the study, right? So it's very important that the practitioners have access to clinical trials. And that's when a lot of these referrals are made. And if your doctors don't participate or are not in that network, then that's why, Blacks are not participating. As it goes, that perhaps most of the doctors that Blacks see, African Americans see, they are not clinician investigators. And so they're not going to contribute their patients to.
And the patient benefits, you get free lab done on a regular basis, you get your free medication, and there are benefits to the patient to be in a clinical trial.
Absolutely.
I wanted to ask, but I didn't want to interject in between Linda's last question. One of my favorite programs in the Association of Black Cardiologists is Children Should Know Their Grandparents. Do they still have that?
Yeah, we do. It's in a different form. And so now it's morphed into Spirit of the Heart. And we also have our community health advocate training, which
that's really important.
Yeah.
So the community health advocate training, would I, as an individual, not as a healthcare direct provider, become trained to provide that information? Okay, so let's give so we want everyone to go to the Association of Black Cardiologists.
Right. So it's abcardio.org. abcardio.org.
Outstanding.
You can just Google it, it'll come up.
And sign up for that, because if we can get the education and the training and then be a community advocate, we should all do that. We're out of time. We're literally out of time. Dr. Underwood, thank you so very much for being a part of the program. Dr. Christensen, always a pleasure to see you, and I look forward to seeing you. This wraps up the January program, and we look forward to bringing more health-centric programs related to health, wellness, and lifestyle in February. This has been the Reset Health, Wellness, and Lifestyle Program with Linda Dorman on OurTV.net. Have a great afternoon, everyone.
Same.
Thanks.